the final passage, dying and bereavement. Judging by studies, we seem more bothered by the prospect of losing our loved ones than we do about dying ourselves. Such studies also show that we worry more about the process of dying, the pain and the loneliness involved, for example, than about the end of life itself. In general, when we are asked if we are afraid to die, most of us deny it and report only mild levels of anxiety. The minority who report high levels of death anxiety are even considered physiologically abnormal. They fear death and they are recommended for treatment. The 5 stages of grief and loss are denial and isolation, anger, bargaining, depression, and acceptance. In our bereavement, we spend different lengths of time working through each step and express each stage with different levels of intensity. Contrary to popular belief, the 5 stages of loss do not necessarily occur in any specific order. We often move between stages before achieving a more peaceful acceptance of death. Many of us are not afforded the luxury of time required to achieve this final stage of grief. Please keep in mind that everyone grieves differently. Some people will wear their emotions on their sleeve and be outwardly emotional. Others will experience their grief more internally and may not even cry. You should try and not judge how a person experiences their grief, as each person will experience it differently. Mourning rituals differ from culture to culture. In the Orthodox Jewish, they cover all their mirrors in their house so they cannot be viewed. Ancestor worship in Asian cultures, is common. Some of the most famous structures on earth result from customs regarding death, the Taj Mahal and the Egyptian pyramids, just as an example. How do we determine that a person has died? For many centuries, people accepted and applied the criteria that now define clinical death as the absence of a heartbeat and the absence of respiration. Currently, whole brain death is the most widely used definition and is based on the 8 highly specific criteria. Other conditions that might mimic death, including a deep coma or hypothermia or drug overdose, must be ruled out. There must be no spontaneous movement and any spontaneous reaction to stimuli, any response to stimuli. No spontaneous respirations for at least 1 hour. The total lack of responsiveness to painful stimuli. No eye movements, blinking, or pupil responses. No postural activity, yawning, or swallowing. No motor reflexes. In addition, the lack of brain activity must occur in both the brainstem and the cortex to be proven as whole brain death. In practice, brain death must be determined with 2 assessments, which each can have a variety of problems. Brain death is also controversial from some religious perspectives. It is possible for a person's cortical functioning to cease while brain activity continues, persistent vegetative state from which the person does not recover. The whole brain standard does not permit a declaration of death for someone in the vegetative state. Bioethics is the study of the interface between human values and the technological advances in health and life sciences. They're called in to determine cases in a lot of acute care settings when people are challenged with the brain death and the actual death of a patient. Euthanasia is usually a scenario when a person is being kept alive by machines or has a terminal illness. Should a person be able to make the judgment that another's life should end? There are two types of euthanasia used. Active euthanasia means deliberately ending someone's life based on the patient's wishes or by a decision made by someone who has the legal authority to do so. Passive euthanasia means allowing a person to die by withholding available treatment. The example would be disconnecting a ventilator or not giving chemotherapy treatments to a cancer patient. Some ethicists and medical professionals do not differentiate active and passive euthanasia. Globally, opinions about euthanasia vary and are often related to religious and political beliefs. Physician-assisted suicide occurs when physicians provide dying patients with a fatal dose of medication that patient self-administers. Several countries tolerate physician-assisted suicide. The Netherlands is the first country to officially legalize the practice. In the United States, Oregon and Washington allow physician-assisted suicide. The Oregon law seems to be implemented well so far and has psychological benefits for the patient. Dr. Jack Kevorkian, a medical pathologist who willfully helped dozens of terminally ill people in their lives, became the central figure in a national drama surrounding assisted suicide. In arguing for the right of terminally ill to choose how they die, Dr. Kevorkian challenged social taboos about disease and dying while defying prosecutors and the courts. He spent 8 years in prison after being convicted of second-degree murder in the death of at least 130 ailing patients whose lives he had helped end, beginning in 1990. Originally, he was sentenced in 1999 to 10 to 25 years in maximum security prison. He was released, however, after assuring the authorities that he would never conduct another assisted suicide. Kevorkian critics were as impassioned as his supporters, but all generally agreed his stubborn and often intemperate advocacy of assisted suicide helped spur the growth of hospice care in the United States. It also made many doctors more sympathetic to those in severe pain and more willing to prescribe medications to relieve it. In Oregon, Dr. Kevorkian's first assisted suicide patient was a teacher, and the state lawmakers in 1997 approved a statute making it legal for doctors to prescribe lethal medications to help terminally ill patients in their lives. In 2006, the United States Supreme Court upheld a lower court ruling that found that Oregon's Death with Dignity Act protected assisted suicide as a legitimate medical practice. This slide is the number of Oregon deaths with the Dignity Act through prescription recipients from 1998 to 2014. So you see a wide variety in numbers. Death with Dignity Act prescription recipients were much higher than the actual death with dignity deaths. Did they change their mind? Did their families convince them otherwise? I don't know the story behind it. Why do people start thinking about their own mortality at midlife? We can take a life course approaching dying. In midlife, most people confront the death of their parents. As a result, they have a growing realization of their own mortality. Older adults are less anxious about death than the other age groups. There are many ways of dealing with one's own death. Many authors try to describe the dying process using a metaphor of a trajectory that captures the period between the onset of death and dying. This figure 16.2 is in your book. It wasn't included in the slides, and I could not find a copy of it anywhere to be able to put on a slide. Elizabeth Kubler-Ross described 5 ways that people deal with death in her book, Death Be Not Proud. The stages we covered a few slides ago, wonder if that could be important and on the final exam. Well, they're here again. Denial, anger, bargaining, depression, and acceptance. People may be in more than one stage at a time and do not necessarily go through all of them or go through them in any certain order. CORE identified 4 types of tasks that a dying person must address: bodily needs, psychological security, interpersonal attachments, and spiritual energy and hope. Kastenbaums and Sells argues that the socio-environmental context within which dying occurs, which often changes over time and must be recognized. Death anxiety refers to people's anxiety or even fear of death and dying. Researchers apply what's called a terror management theory as a framework to study death anxiety. The theory addresses the issues of why people engage in certain behaviors to achieve particular psychological states based on their deeply rooted concerns about mortality. Facing death on a regular basis often forces people to confront their death anxiety. Law enforcement, fire, soldiers, those are many of the people that face it every day. Neuroimaging research supports the use of terror management theory to study death anxiety. The components of death anxiety include pain, body malfunction, humiliation, rejection, not being, punishment, interpretation of goals, being destroyed, and negative impacts of the survivors. Each of these components can be assessed on 3 levels: on the public level, on the private level, and on the unconscious level. Learning to deal with death anxiety is important. Live life to the fullest, write your own obituary, plan your own death and funeral services, and explore death education programs are ways that they have used to meet and deal with the death anxiety. End of life issues. People who are dying must create a final scenario. End of life issues include the management and the final phase of life, after death disposition of one's own body, and memorial services, and finally the distribution of the assets. Making such choices known about how you do and do not want your life to end constitutes that final scenario. One of the most difficult and important parts of a final scenario for most people is the process of separation from family and friends. Deciding whether to have a traditional funeral as part of the creation of one's final scenario. Hospice is an approach to care that emphasizes pain management or palliative care and death with dignity. Palliative care is focusing on providing relief from pain and other symptoms of disease at any point during the disease process. The hospice program is markedly different from the hospital or any home care. People usually decide on hospice care when they have a life-limiting illness, cancer, AIDS, cardiovascular disease, or other terminal conditions. People can come and go out of hospice care as their condition changes. Although hospice is a valuable alternative, it may not be appropriate for everyone. Hospice provides supportive follow-up services to surviving family and friends as well. Hospice provides loads of support, but the primary client, the patient, is not ready to halt anything or everything other than palliative treatment. Hospice is not the best choice. Pain control, comfort measures, familial and pastoral support are common assistances, as well as social services, nursing care, and respite care for the loved ones. Will the care be provided in the home, or will the client be moved into a setting like a long-term care or an actual hospice home? These are things that also need to be thought of. Hospice is covered by many healthcare programs, but there may be out-of-pocket expenses for pharmacological coverages. Most of the time, the nursing care and all the rest is covered. And most hospices have, like for lack of a better term, a broad base of donations that help pay for their hospice clients. Thinking about end-of-life matters raise complex legal, political, and ethical issues. It is essential that people make their wishes known. There are two ways to make one's intentions known. A living will, which is a person simply states his or her wishes about life support and other treatments. A healthcare power of attorney, in which an individual appoints someone to act as his or her agent in making healthcare decisions when they are no longer able to make those decisions for themselves. A living will or a durable power of attorney for healthcare can be the basis for a do not resuscitate order, which means that no cardiopulmonary resuscitation will be done, and it would not be started if the patient's heart stopped beating. Most ambulance and fire crews will ask on arrival and will look in obvious spots like the refrigerator, near the phone, things like that. But they will have to start CPR if there's nothing known about the patient at hand. One major concern regarding end-of-life decision is whether the person is cognitively or legally able to make that choice. There are two types of determination: the capacity to make the decision, which is a clinical determination, or the competency to make the decision, which is usually made legally. The grief process varies by individual. Bereavement is the state or fact of being denied the presence of someone or something. Grief is a deep and emotional distress caused by a bereavement or a loss. Mourning is the outward sign of grief for a loss. Mourning is highly influenced by our cultures. Unlike bereavement, over which we have no control, grief is a process that involves choices on coping. Grieving individuals must acknowledge the loss, work through the turmoil, adjust to the absence, and loosen ties to the deceased. There is no right way to grieve, and grieving does not have clear demarcated edges or stages. Grieving is an individual process. People need at least a year to begin to recover, and 2 years is not uncommon. Dealing with the death of friends is often difficult for the young or the young adults. There are many typical grief reactions. The psychological side of coming to terms with bereavement is called grief work. Experience of grief tend to involve coping, affect change, a narrative, and a relationship. In addition to psychological grief reactions, there are also physiological ones. The term anniversary reaction refers to changes in behavior related to feelings of sadness on the anniversary of a death. Grief can last a long time, but most people move on with their lives in a relatively short period of time. How openly grief is expressed varies considerably from culture to culture. Two integrative approaches have been proposed that are specific to the grief process. The four-component model is one approach. It proposes that understanding grief is based on four things. The context of the loss, which is the context is the stuff that hooks two things together or two people together. The continuation of subjective meaning associated with that loss. This can range from evaluations of everyday concerns to major questions about the meaning of life. Changing representation of the loss relationship over time and getting on with life. The role of coping emotions, regulations, processes, achieving, restoring, and sustaining physiological well-being. Implications of this view are that helping a grieving person involves helping them take meaning from the loss and encouraging people to express their grief. This may actually not be very helpful, but most people try. An alternative view called the grief work as a rumination hypothesis not only rejects the necessity of grief processing for recovery at loss, but views extensive grief processing as a form of rumination that may actually increase the person's distress. The four-component model poses this. Dealing with grief is a complicated process that can only be understood through a complex outcome that unfolds over time. Helping grieving people involves helping them make meaning from the loss, and encouraging people to express grief is not always helpful. As alternative view, called the grief work or rumination hypothesis, not only rejects the necessity of grief processing for recovery from loss, but views extensive grief processing as a form that may actually increase the distress. The dual process model of coping with bereavement integrates existing ideas and regarding the stressors. Loss-oriented stressors are those having to do with the loss itself. Restoration-oriented stressors are those related to adapting to the survivor's new life situation. The distinguishing feature of the DPM is that it shows how bereaved people cycle back and forth between dealing mostly with the grief and trying to move on with life. The dual process model of coping with bereavement shows the relationship between dealing with the stresses of the loss and moving on with the reorientation. When a person never has closure and the grief continues to interfere definitely with their ability to function, that individual has complicated or prolonged grief disorder, which is distinguished from depression and from normal grief in terms of the separation of distress and traumatic distress. Symptoms of separation distress include preoccupation with the deceased to the point that it interferes with everyday functioning, upsetting memories of the deceased, longing or searching for the deceased, and isolation following the loss. Symptoms of traumatic distress include disbelief about the death, mistrust, anger, and detachment from others as a result of the death, feeling shocked by the death, and the experience of physical presence of the deceased. For some people, feelings of loss are debilitating and don't improve even over time. Knowing this is complicated grief. It's sometimes called a persistent complex bereavement disorder. In complicated grief, painful emotions are so long-lasting and severe that the individual has trouble recovering from the loss and resuming their own life. Experiencing death is the only natural context loss of loved ones that may come after experiencing the loss of pets. There can be a correlation drawn between those two losses in the younger groups. Preschoolers tend to believe that death is temporary and magical and something dramatic that comes to get you in the middle of the night, like a burglar or a ghost. The child from age 3 to 5, the stage of the child is egocentric, which means they're child-focused. They believe that the world revolves around them. The death of a loved one will be very self-focused, where they believe that they are responsible for the death. They may feel abandoned, and the grief of losing a loved one as part of a disaster or crisis event may interrupt age-appropriate activities and force the child to address issues for which they are not developmentally ready to handle. Emotions present can be greatly from sadness, anger, anxiety, and guilt. The child from age 6 to 12 is the school-age children. At the stage, they learn basic skills but attach their cultural values to it. Death of a loved one during a disaster or a crisis event can result in a child not wanting to leave home or hoping to reassure the safety of others. For school-age child, like the younger child, grief crisis may interrupt age-appropriate activities and force the child to address issues that they are not developmentally ready to handle. Children at this age might believe that certain behavior will bring their loved ones back. They might be preoccupied with the fear. They might also experience sadness, anger, anxiety, and guilt. Children show their grief in many ways, including physiological or somatic, emotional, which is intrapsychic, and behavioral. This pie chart shows the different type of things that you may see in children that are having disabling grief. The adolescent, age 13 to 19 years old. Adolescents, more than school-age children, often deal with self-esteem and identity issues. They want to differentiate from their parents. If they lose a loved one during a disaster or a crisis event, they may feel guilty for what they might have said to a person before that person died. Adolescents, just like the young and the school-aged who experience this kind of loss during a disaster or a crisis, may experience an interruption in age-appropriate activities, since this kind of loss can force an adolescent to address issues for which they are not prepared. Adolescents often express their grief and loss through their body language, acting out, and in addition, adolescents may be internally preoccupied with death, which might be manifested through poor school performance. The young adult, age 20 to 40, young adults can be devastated by the death of a loved one during a disaster or a crisis event. For example, losing one's child can be paralyzing for parents. Parental grief can be a long-lasting and powerful experience and is influenced by the developmental tasks expected by parents. The parents might blame themselves for not protecting the child better during the crisis or during the disaster. Their emotions may range greatly and include such things as loneliness, sadness, disbelief, anger, anxiety. Young adults losing a spouse or a partner might feel emptiness and isolation, and their social connections might change as they were no longer a couple but an individual. Losing a spouse or a partner at this age means not only grieving, but assuming often unfamiliar responsibilities and roles that the deceased may have been doing, including helping with children through the grief. Becoming a widow as a young adult can be especially traumatic. The middle-aged adults, 40 to 60 years old. Middle-aged adults, similar to young adults, can be badly impacted by the sudden loss of a loved one during a disaster or a crisis event. They might grieve the loss of their children, the potential future grandchildren. They may feel guilty for not having been able to protect their children. Losing a spouse or a partner during a disaster or crisis event can leave middle-aged adults with often unfamiliar responsibilities and roles, experiencing financial hardship, and or dealing with the grieving children as well. Middle-aged adults might grieve future plans for retiring together. Losing one parent often leads to redefining relationships with other family members. Losing a parent at a young age can lead to worries about dying young. When an older parent dies, the adult child is usually more accepting of the death and happy that the parent's suffering is over. The elderly adult, 60 plus years. Elderly adults, depending on their age, have acquired memories, cognition, material things, accomplishments, spiritual realizations, and losses. They have often experienced multiple losses such as jobs, health, independence, social roles, family living surroundings, and loved ones. Although loss is often expected during this age, unexpected losses of children and or spouses or partners during a disaster or crisis can be detrimental. Children are often also caregivers. Loss of a spouse or a partner might result in feeling more dependent on others. Often the elderly lack the social support needed, which can be detrimental during this time of loss. Losing a partner late in life is a deeply personal loss. Grief can occur for as long as up to 30 months. Survivors with close confidence are better off than those with many acquaintances. Bereaved widows and widowers tend to give their marriages more positive ratings than the non-bereaved. If you look in your book, there's a table that shows this 16.5. The loss of a spouse or partner can be especially traumatic after a really long relationship. Older women, as we discussed in a lecture, I think a couple of weeks ago, tend to sanctify their deceased husbands. It serves to validate that the marriage was strong and that the widow is good and worthy and she is capable of rebuilding her life. Gay and lesbian couples often face other feelings and reactions on top of normal grief because of the lack of family acceptance. They may not be welcomed into the funeral setting, so they're grieving not only the loss, but they're not even allowed to participate in the saying goodbye. Understanding death through the interaction of psychological and sociological forces is important. As with beginning of life, death is also a complex interaction of biological, physiological, sociocultural, and life cycle factors. Perspectives on what happens after death is also an interaction with these factors.